So thank you so much, Dr. Lindsay Fourman, for doing this. I don't think many of our patients know you in the lipodystrophy world. So can you please introduce yourself, your title, and some of your work?
Sure. Well, thank you so much. Thanks for having me for this session. Definitely excited to be able to talk to the community about this really important topic of lipids and heart health. So I'm Lindsay Fourman. I'm the Associate Director of the Lipid and Metabolism Clinic at Mass General Hospital in Boston. And as part of that clinic, we're really trying to create a home for patients with lipodystrophy. That's really, as I recognize that that's a major unmet need. And especially in the Northeastern United States, there is really no place for patients, but even nationally, I would say there's not many centers. And so we're trying to make sure that we're a home for patients with lipodystrophy. In addition, we have a lot of interesting research going on that's very complementary with our clinic. And towards the end, I will kind of highlight one of the studies that we have going on, a biorepository that we are actively seeking patients for. But definitely that's an important mission, in order to improve the lives of patients with lipodystrophy. A lot remains unknown, and we really need to push the path forward. So I'll just get started. Here are my disclosures. They're all unrelated to today's talk. So just kind of to take a step back, lipids, most people don't even know what that really is. So lipids can really refer to anything from cholesterol to triglycerides. There are other lipids in the body as well. And they do serve vital functions in the body. I know we always talk about, we don't want a high cholesterol, we don't want high triglycerides, but why do we have these pesky, pesky molecules in our body to begin with? So they really are important as well. So cholesterol actually is part of what sort of coats our cells, the cell membrane. So it is important. Cholesterol also gives rise to bile, which breaks down our food. And also gives rise to certain hormones. So like estrogen, for example, is actually derived from cholesterol, as well as vitamin D produced by the body. All very important functions of cholesterol. And then triglycerides, so that's really just stored fat, but that is important. That's actually how we store excess energy so that when we're not eating, we have something to use to break down and use for energy. Whether you eat fat or whether you eat extra calories in the form of carbohydrates, for example, that can get stored as triglycerides and then used by the body during times of fasting. So lipids travel through the blood, and they don't really, if you've ever seen mixing oil and water, doesn't go well. It doesn't mix together. So you need to actually have a molecule to carry it around, and that's called a lipoprotein. That's the fancy word for it. It sort of looks a little like these chocolates, I thought, kind of like a hard outside and then a soft inside with all the triglycerides in the middle. And so when we look at the lipid panel, we're looking at some of those lipoproteins and then some of just sort of the absolute amount of cholesterol and triglycerides. So here's actually an example of a real patient's lipid panel, someone who has lipodystrophy, and this panel may look familiar. It may look a little like your lipid panel, maybe, where you can see that it gives you the total cholesterol, the HDL cholesterol, the triglycerides, and the LDL cholesterol. And a couple of really common things are on here, so I chose this particular panel. One is the triglycerides are high, which is very common for patients with lipodystrophy. Another is that a lot of times when the triglycerides are high, the HDL also is low, and the HDL we'll talk about it, it's a good cholesterol, but those kind of go reciprocally, so that's common. And then another thing is a lot of times, because when the triglycerides get to be too high, normally you get an LDL cholesterol that's calculated on the panel. It's not measured directly. It's sort of calculated from everything else. But if the triglycerides get too high, above 400, it won't calculate. So common scenario that a person with a high triglyceride level is missing an LDL, and it can be measured, but it has to be a direct measurement. So we'll talk about that as well. So of this panel, you're getting sort of the amount of cholesterol, the amount of triglycerides, and then the amount of two important lipoproteins, the HDL and the LDL. So LDL is your bad cholesterol. That's kind of, how we think of it. And the reason why we think of it as the bad cholesterol is because studies have shown again and again that the higher your LDL, the higher your cardiovascular disease risk. And so here is just a graph to sort of show all these different studies have been pulled together. And the higher your LDL on the x-axis on the bottom, the higher your coronary artery disease events over here. So the lower, the better. Getting it very low lowers the risk. The reason is because LDL really does directly contribute to the pathophysiology of heart disease by getting into the vessel wall and causing a plaque to form. And when the plaque forms, it can block the vessel, or it can also sort of burst and actually occlude the vessel suddenly, which is a heart attack. So it really is involved in the pathogenesis of heart disease, and the lower, the better. So like I mentioned, this person, their LDL was not able to be obtained from the regular panel. And I mention this because sometimes patients with high triglycerides, time and again, go for their lipid panel and they never have their LDL measured because the triglycerides are high and the person just orders like a standard lipid panel. It comes back, it's missing an LDL. And so you never know what your LDL is. And I just mentioned this that, sometimes you should mention to your doctor then to order a direct LDL because that will actually tell you the result. And LDL is very important to know based on what I've mentioned about how it's involved in the pathogenesis of heart disease. And so everyone should know what their LDL is. And so here we measured the direct LDL, and here it is 53. So not too bad. We'll talk about what the numbers mean in a second, but this is a good number. And so LDL, what is a good number? So it's really not one size fits all. There's no one normal range. Sometimes in the, like if we go back to what they call the normal range in the results, it would say like above 130, it's going to be lighting up as red, that it's abnormal. But really, it sort of depends on what your overall risk is, what we want your LDL to be. So it's kind of like a sliding scale of what's normal. So I sort of made it an analogy of like, how much smoke we would tolerate in the kitchen versus like on an airplane. Like if there's any smoke on an airplane, it should be an alarm. Like you should land the plane. This is very concerning. If there's smoke in the kitchen, it's like, okay, kind of expected. It's not a big deal, we'll monitor it. So if you have a very high risk of heart disease, we want your LDL to be very, 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 very low because we want to do everything that we can do to control your risk. And so if you have other risk factors, if you have diabetes, if you have high blood pressure, fatty liver disease, high triglycerides, then we want your LDL to be extremely low because we want to try to tolerate no LDL elevation because we know it's involved in the pathophysiology of heart disease. On the other hand, if you are an otherwise healthy person and your LDL is 140, you have no other risk factors for heart disease, that's okay. LDL of 140, because your risk of heart disease is otherwise so low, we don't necessarily need to tighten control of that number. So it is even a little more controversial than that, as I'll show. American Heart Association guidelines differ from European guidelines, and there are actually new European guidelines just released about 2 or 3 weeks ago with new cutoffs. But I think they're getting lower and lower in terms of what we want to do with your LDL to minimize cardiovascular disease risk. But I'm just going to go over the American Heart Association guidelines first. Those were since 2019, so they're actually getting a little old. But this is for primary prevention. And that means that if you've had a prior heart attack before, that's not this algorithm. If you have prior heart attack, we would want to control because you have a high risk based on what I said before about like smoke in the airplane, we would want to control your LDL very tightly. But if this is for primary prevention, someone that doesn't have had a heart attack already, this is how we would kind of approach it. And so the guidelines say that if your LDL is above 190, which is pretty high, you should be on a statin. Like don't even do anything else. Just like start a statin, lower it. If you have diabetes, you should also start a statin. So if you're over the age of 40 and you have diabetes, everyone should be on a statin because your risk of heart disease is high with the diabetes. And so it's just recommended to give everyone a statin. But if you don't have either diabetes or a prior heart attack or an LDL above 190, then it's sort of this algorithm of figuring out what your cardiovascular disease risk is And then once you calculate that, to treat based on the risk. So if you have a higher risk, to basically give statins and treat it if it's higher. So it's kind of that smoke in the airplane concept, but it's sort of like if you see that the risk is high, treat and lower the LDL. If you have a low risk, you don't need to treat to lower the LDL. Now, I just wanted to also point out that beyond sort of in terms of this calculation, I'll show kind of calculators in a second and what goes into that. But there's also what they call these like risk enhancers that are not part of the calculator, but are things that would raise the risk. And so things like inflammatory diseases, like if you have an autoimmune disease, if you have like metabolic syndrome where you have a lot of complications of like hypertension, fatty liver, high triglycerides, those would be actually reasons that you should sort of shift up your risk and start treatment at a lower threshold. Now, this is the European guidelines. This was released 2 weeks ago. So you're on the cutting edge to hear these guidelines right now. But basically, what they sort of say is they want everyone to have a pretty low LDL. So if it's above 116, even if you have a low risk, you should be treating your LDL according to these guidelines. And then you should lower your LDL even further based on what your overall risk is. So, for example, if you have diabetes for over 10 years, your LDL should be less than 70. And if you have atherosclerosis, so plaque in your heart, it should be less than 55. So that's kind of the take home. But the higher your risk, the lower your LDL should be. That's kind of the general concept. And the other concept is like the risks keep getting, it's sort of like the goals keep getting lower and lower. So like with time, I think we've just realized that this is a risk factor. It causes the pathogenesis of heart disease. And so a lower LDL is going to be better. And if your risk is high, we should tank it as much as we can, as low as we can. And we've gotten better and better with that due to better therapies coming out and that allow us to do that. So I think the targets have sort of tightened based on the fact that we can achieve lower numbers. So this is an example of a risk calculator. You should not probably be running your own risk calculator. I'm not expecting that, but just to kind of know like what risk factors play into thinking about your overall cardiovascular disease risk. So older age is associated with higher risk. Being male is associated with higher risk. And then blood pressure, higher blood pressure is associated with higher risk. And then the cholesterol numbers. So higher LDL is associated with higher risk, and higher HDL is associated with lower risk. So HDL is the good cholesterol, higher is better on that. Diabetes is associated with higher risk, and smoking is associated with higher risk. And then being on blood pressure medication is associated with higher risk. So this is just an example, but if you think of all the, blood pressure, age, sex, diabetes, those are kind of the big ones that would make you be at higher risk if you have higher like diabetes or high blood pressure or being male or older age. And so that kind of increases your risk and makes it more likely that we'd want to lower your LDL further down. Sometimes something called a coronary calcium score can be helpful to sort of decide for people if they don't know if they want to take a statin or lower your LDL. So let's say like you have someone who, their risk is borderline, like you do the calculation and you're not having massively high risk, but it's not zero either. Sometimes in discussions with patients, we're not, they don't know, they're on the fence, or we just feel like it's a bit borderline of whether to start. And so as sort of a tiebreaker, sometimes I order this coronary calcium score, which is essentially like a CAT scan or an X-ray that takes a picture of the heart. And this is the heart here, and this is one of the heart vessels. And you can see all of these bright spots, and that's actually calcium deposited in the blood vessel. And that is part of the plaque. Sometimes people can have calcification inside that plaque, and that can light up on the X-ray. And so that's helpful. If it is positive, it does make me say, okay, you definitely should be treated. And according to that European guideline, because you have atherosclerotic cardiovascular disease, your target would be less than 55 for LDL. There is some caveats in terms of interpreting this. First of all, not all plaque is calcified. There is non-calcified plaque that doesn't have any calcium in it. So just because your calcium score is 0 does not guarantee that you don't have any plaque. And younger people in particular are less likely to have calcified plaque. And so if you were young and did a calcium score and told me it was 0, I wouldn't really be, too impressed. I'd say, okay, well, you could still have plaque. It just could have missed it because you're not likely to have calcified plaque at a young age. If you're older, if you're maybe 60 and up and you do this and it's negative, I would be more convinced that, okay, it's likely that you probably don't have any plaque if at that age you still had no calcified plaque. The other point is that this is only a snapshot in time. So don't do a calcium score and then think that you're set for life, that you did it when you're 6 years old and now like, oh, I'm never going to have plaque because I did it once and I never have it. And I didn't have it, so I'm in the clear. Plaque can develop slowly over time, due to these risk factors for heart disease. And so, you don't want to get like false reassurance where you think you never need to be on a statin based on one test that you did. And then the other point is that this is a little counterintuitive, but calcified plaque can actually increase with statin use. And someone would say, wait, like, why would I want to take a statin and increase my calcification? That makes no sense. The reason is it's just changing. It's not making you have more plaque. Statins actually do the opposite, but it's changing the plaque to actually make it more stable plaque that's less likely to rupture and cause a heart attack. And when it does that, the appearance actually looks more calcified. So it's making your plaque actually better, but in doing so, the calcium score will actually appear higher. So you should not use it it's not useful to trend it. A lot of times people ask, oh, I checked it and it's this, can I do something about it and then repeat it to see how we're doing? No, it's not useful to be able to trend your calcium score once you start a statin, because statins actually can increase the number. So what do we do? So how do we treat high LDL? So first, lifestyle. Lifestyle is really important, but for LDL, it doesn't change as much with lifestyle. Sometimes I've had patients who have adopted a very extreme diet, like a ketogenic diet, eating, all like meat, like roast beef all day long, bacon and cheese all day. And then like when I say, okay, don't do that extreme diet anymore, then their numbers can improve. But usually if you don't have that kind of extreme diet, it's unlikely that it's going to be radically changed by changing your diet, although it could have some benefit. So avoiding foods high in cholesterol and saturated fat, so like egg yolks, fried food, red meat, whole milk, those are foods that have a lot of cholesterol or saturated fat. But really, we think we kind of go towards medication because in the absence of an extreme diet, what you do is not going to radically change your LDL. So statins are the first line. They're sort of like the answer. A, B, C, and D is statins. That's kind of what we really want to use because we have really good data that statins reduce cardiovascular disease risk. So not that they just lower LDL, making the number in the computer look better, but also that they actually prevent cardiovascular events. So there's event outcomes data that shows that they actually do lower your risk of actual heart attacks, strokes, heart failure, those sort of complications. And so we want to try to actually use them to lower LDL and thereby improve cardiovascular risk. So things like atorvastatin or rosuvastatin, they can lower your LDL by about probably like a range, depends on the dose and on the statin, but could be about 50% reduction. The biggest side effect with statins that everyone always talks about is muscle aches. A lot of times the statin is not really causing the muscle ache, but once you're on a statin and you have a muscle ache, you can't help but wonder if it is related. Sometimes taking CoQ10 can help with that, or switching statins and seeing if you tolerate another statin better. Some people just tolerate one better than another. Now, I'm not going to go through every single drug. That would be way too much. But just to sort of mention that if you don't tolerate a statin, there are alternative options. One of the ones that I think is kind of like one of the best things to use in place of a statin would be something called a PCSK9 inhibitor. The names for that would be Repatha or Praluent. Those are actually injections that you take every 2 weeks. You take them yourself at home. There's a pen for it. Very well tolerated, doesn't cause any of the muscle aches that we see with statins. So if you can't tolerate a statin due to muscle aches, that's a good thing to discuss with your doctor about potentially starting a PCSK9 inhibitor. And then there's some other ones that are pills that tend to not have as big of an impact in lowering LDL, but we do use them when we have to if you either don't meet your target with a statin or you can't tolerate a statin. So I thought it would be helpful also just to sort of think about this like cardiovascular risk prevention with statins, just to understand like how this works, because I think may not be what you think. So if we say a statin reduces your risk of something of a cardiovascular event by 25%, that sounds a lot, which it is a lot as a relative risk reduction. But if you really think about it, if we treat 100 people with statins who have high risk, like we decide you need a statin and I start statin medications, let's say the risk that this population would develop an event is, let's say, like 12% to begin with. And I reduced the risk down to 9%. So I've sort of achieved a 25% reduction by going from 12 to 9. That's like the relative risk reduction is 25%. But if you look at this numerically, if it was 12% to begin with, that essentially means that 88 people who I treated would have had no event no matter what I did. So they were fine either way. If I hadn't started statin or I started a statin, they would have been okay. We can't predict who that is, but they would have been okay either way. And then without treating any of these people, 12 people would have developed an event, but because I treated them, only 9 people developed an event. So I basically prevented an event in 3 people by treating 100 people. So, you need to treat like 30 people with a statin to prevent 1 event. Now, I'm not saying you should not take a statin. I think that actually preventing 1 event is actually great, and it could be life-changing for someone. I mean, these events can really debilitate and cause death even. And I'm also, the risk of taking a statin is very low. Muscle aches, you would know if you had it, you would stop it if you do. It's very worthwhile to take a statin. But I'm just trying to explain, I think sometimes it's confusing to people what you mean by, well, what do you mean by 25% risk reduction? Or what do you mean by, how many people actually benefit from a statin? I think it's just kind of helpful to see this kind of laid out. The other kind of thing that comes up from here is 2 other points. One is that 9 people here develop an event no matter what. That's what we call residual risk. It's risk that we haven't really addressed. I would love to give a statin and all of these people develop no events. That would be the goal. And so I think that this kind of highlights that there is a need for further research to try to, really get rid of this residual risk completely and be able to use therapies that really can prevent all events in all people. So that's just kind of, the goal here for the long term. The other point is just, when we talk about that sliding scale of like what our target is, a lot of people in my clinic will kind of ask me like, okay, I have a low risk, but I can reduce my risk by 25%. Like I want to do that, right? Like I would love to do that. And the reason why it doesn't always pay to do it for everyone is because if your risk is only 2%, and I say that we can reduce it by half, that's going down to 1% from 2%. That's a 1% reduction, so that's a very small change. Even though it was a 50% reduction from 2 to 1, you're really only in 1 in 100 people really going to make a change there. And so that's kind of why we treat when the risk is higher, because then that reduction actually becomes more substantial from like an absolute reduction standpoint. And we don't need to treat as many people in order to prevent an event. Kate, did you have a question?
Yeah, question. Are there any other benefits other than like preventing that that extreme episode?
Yeah, I mean, statins have been studied for preventing any like major adverse cardiovascular events. So heart attacks, stroke, peripheral vascular disease, heart failure. Statins also do have some, in addition to lowering cholesterol, we think that they have some like off-target effects to reduce inflammation in the body as another mechanism of how they reduce these events. But the real outcomes that we're trying to prevent are those like major cardiovascular events. Okay, so moving on to triglycerides. So triglycerides, like I said, are fat that you have in the body that you have to store. And triglycerides are sort of a marker of cardiovascular disease risk. High triglycerides are generally associated with high risk. Also, very high triglycerides above 500 and particularly above 1,000 can start to increase the risk of pancreatitis. Which I think for many patients with lipodystrophy is unfortunately something that they experience. And so trying to control those triglycerides becomes very important, especially in those patients with very high levels. And so you can just see here kind of like in high triglycerides go up and the risk of pancreatitis really goes up, especially once it gets to be above 1,000 in particular. So unlike what I had said about LDL, triglycerides are very sensitive to lifestyle and health, which is good and bad because it means it could easily go up. It also means that changing your lifestyle can make it go down. And people may have experienced this. I know talking to my patients with lipodystrophy, they say, oh, I went on vacation, I was drinking more, or I went and had pizza, or whatever the case. And then they checked their triglycerides and they were 2,000. And sometimes that's all it took to develop an episode of pancreatitis. So it's very sensitive, but it also, that's a good thing for when you're trying to control it, because I've also seen patients with a high level, and then just with dietary changes, they're able to bring it down significantly. So just in terms of what in the lifestyle is affecting it, so alcohol, saturated fat like fried foods, refined sugars, so like a lot of the like processed foods that have a lot of carbs in them can raise triglycerides. And then just in general, excess calorie consumption, so like gaining weight because you're eating a lot of extra energy, decreased physical activity, and smoking can all increase triglycerides. And then in terms of medications, drugs, or medical problems that can play a role, so weight gain, uncontrolled diabetes, hypothyroidism, pregnancy, and then estrogen, so like oral birth control pills can raise triglycerides, steroids, if you need to receive steroids like prednisone or hydrocortisone for any reason. Hydrochlorothiazide can have some effect, which is a blood pressure medication. And then antipsychotics, particularly the kind of atypical antipsychotics, so something like Seroquel or something like that can raise triglycerides. I'd say like the biggest thing to think about is the birth control pills, the oral estrogen, because that is maybe more optional than some of these other medications that you might be taking. And there are other ways to do birth control, and even taking an estrogen that's transdermal, not oral, so like a patch, would be better for triglycerides than taking a pill. So in terms of treating triglycerides, it's elevated if it's above 150. So that's really when the lab will start to show up in red and say that it's abnormal. We really start to get worried when it's above 500 about the risk of pancreatitis, and particularly when it's above 1,000. And so for mild elevations between 150 and 500, we're really thinking about lowering it to reduce the risk of cardiovascular disease. When it gets to be above 500, we're really frantically trying to lower it to prevent the risk of pancreatitis, because that can be a very serious thing for patients, especially patients that have had repeat episodes of pancreatitis. So in terms of the cardiovascular risk, if we go back to the American Heart Association guidelines, actually one of those risk enhancers that I mentioned that would kind of inflate your risk above what you calculate in a calculator is persistently elevated triglycerides above 175. So that would sort of make you more likely to want to use a medication to reduce cardiovascular risk. So lifestyle. So what can you do with your lifestyle to try to reduce your triglycerides? So trying to lose weight, especially if you are overweight, can help. It's also been seen, there's some data that, in lipodystrophy, even a BMI on like the lower end of normal is best. Even like if you compare a person with and without lipodystrophy at like what's a normal healthy BMI, people with lipodystrophy, the normal healthy BMI is lower than a person without lipodystrophy. In addition, diet. So if your triglycerides are below 1,000, in general, what we would recommend is like a heart healthy type of diet with healthy fatty acids like fish oils. So like eating fish, olive oil, avocado, like healthy fats. Those unsaturated fats are actually good for triglycerides. And also avoiding refined carbohydrates. So trying to avoid processed foods or baked goods, things like that, that have a lot of like, they're not like whole grain types of carbs. They're just kind of simple carbs that end up getting converted to triglycerides. And then if your triglycerides are over 1,000 at that point, because your risk of pancreatitis is high and because your body is having a lot of trouble processing fat in general, instead of having this like heart healthy fat diet, we actually recommend just trying to limit fat in the diet at that point. So really having a very low fat diet, because anything that you eat is not being well processed at that point by the body, and it's just becoming circulating triglycerides. So any fat you eat is actually just sort of staying in the blood at that point. So until it gets below 1,000, should try to limit fat. Once it gets below 1,000, eating healthy fat is the right thing to do. And then exercise is very good to lower triglycerides. Avoiding alcohol, and then also trying to get a better control of diabetes. A lot of times when people have uncontrolled diabetes, that raises the triglycerides, and when you get better control over diabetes, triglycerides also improve. So in terms of medication, that's lifestyle, and that's a very big piece. Like I mentioned, triglycerides are very sensitive to lifestyle, but also we often do use medications as well to further get it under control. And so statin medications, so as I mentioned, when they're 150 to 500, we're more focused on cardiovascular risk. And so we treat it like the way we treat high cardiovascular risk with high LDL, which is statins. Statins also do have an effect on lowering triglycerides, so they lower it by like 10 to 30%. So not massively, but they have a generally positive effect. The real reason, though, to start statins is that cardiovascular risk reduction, though, like I had shown on the prior slide, where it's a risk-enhancing factor. Beyond statins, if your triglycerides are certainly above 500, where it's in that pancreatitis risk range, then we get a little bit more aggressive to actually want to fix the triglyceride number itself. So not just addressing the risk of cardiovascular disease, but actually trying to really avidly lower the triglycerides. And so for that, we use fibrates. So those can get a triglyceride reduction of about 50%. So like fenofibrate or gemfibrozil. So that's really what we would add on for triglycerides above 500. And then fish oils are great. They are often over the counter. So it's a great thing to take. I mean, it's also great to eat fish, as we talked about on the prior slide with lifestyle. There is one in particular, Vascepa, that does have cardiovascular benefit that's been shown in studies. So usually if we're doing fish oil and we can be on Vascepa, because the data there is just there that it improves cardiovascular risk, I try to pick that one. But really any of them should have a beneficial effect to lower the triglycerides and may also help with cardiovascular risk.
I have a question.
Yeah.
I have many, but specifically about the PPAR gamma agonist. So we know that familial partial lipodystrophy type 3 have a mutation in the PPAR gamma. So medication like Actos, right? This is the PPAR gamma agonist. Will not work on them, correct? So this is not an option for them, I guess. And the second question regarding the PPAR gamma agonist is that for some people, I don't know in lipodystrophy, but people with diabetes, it can cause weight gain. So is this something that contradicts what we want to do in lowering the triglycerides?
Yeah, that's a really great question because I feel like that is confusing the way this looks. So this is actually PPAR alpha. It's not actually related to pioglitazone, which is Actos. But I'm glad you mentioned this because I'm sure the slide is going to be really confusing otherwise. So these are fibrates, which is PPAR alpha. It does not relate to PPAR gamma. So anyone with any lipodystrophy can take it, even people that do have a PPAR gamma mutation. and weight gain is not an issue for this. But back to what you asked about the PPAR gamma. So pioglitazone is a PPAR gamma agonist. It's a diabetes medication. It's supposed to increase the sensitivity of your fat to insulin, so it increases insulin sensitivity. And so sometimes for patients that are very resistant, it's a medication we like to use. Now, actually, the fact that there are people with PPAR gamma mutations, this has been studied a lot to see if would they be actually a good candidate for pioglitazone. Maybe it will work better in them because it's kind of like tackling the issue that they have. So this has been studied extensively, and the data is very conflicting. I would say the data is no one is that excited about it. It's not like, oh, this works super well, like we want to do it. It's kind of like maybe in a person with a PPAR gamma, we could give it a try. Maybe it would help them, but if it doesn't, we're just going to move on to the next thing. Pioglitazone, the PPAR gamma agonist, does cause some weight gain, and it can actually cause some fluid retention. So it's something that we do monitor for. I would say it's something we counsel patients about and monitor, but it doesn't necessarily stop us from using it. If a particular patient is started it and then all of a sudden calls and says that, oh, I'm noticing that my legs are swollen or I'm putting on weight, then maybe in that particular patient, we would say, okay, this is not for you. Let's stop it. But it doesn't usually, and also if you have a patient we don't want them to have fluid retention because they have heart problems or something else, we might not use it for that reason. But usually it doesn't stop us. It's just something we counsel about. But thank you for raising that because I'm sure many people probably are going to think that this is PPAR gamma and that it's the same thing. So yeah, it is separate from that. And I have plenty of patients with PPAR gamma lipodystrophy who are on these who have a benefit with their triglycerides.
Thanks.
Okay. So HDL cholesterol. So HDL is sort of the good cholesterol. And what it is thought to be, it's thought to be kind of like a lipoprotein that sort of picks up cholesterol from around the body and scavenges it and brings it back to the liver. So LDL is sort of, one train going into the artery, and HDL is going around and picking it up and bringing it back to the liver. So it's thought to be a good thing. And that's why if, you probably have heard like HDL high is good. This is actually to a limit, and we're starting to learn a little bit more about HDL. And so here is sort of, some curves from some epidemiologic studies that actually show that HDL is more like a U-shaped curve, meaning that very low levels are associated with a higher mortality and are bad. So higher is better. That's what, everyone says. That's kind of like this side. But if you do get very, very, very high, it also is associated with higher mortality. And so that's why it's kind of a U. The reason may be that high HDL, if you have a level of 120 or something very high, normal is greater than 40, and then it's thought to be good if it's greater than 60. But let's say it's like 120, super, super high. It might be like not functioning properly. So while the cholesterol is there floating around, it's not doing its job of actually scavenging and going to the liver as it's supposed to do. And it's kind of just not working. It's kind of like, it's been likened, in this analogy here where it's trains. If you see a lot of trains, you might think, great, there's so many trains, but maybe there's like some blockage. There's like construction on the track and all the trains are just backing up. So it looks like there's a lot of trains. It doesn't mean that they're working and doing what they're supposed to do. And so that's just one point about HDL. The other point was just as a reminder about this kind of reciprocal relationship that oftentimes people with high triglycerides have low HDL. So when you have a patient with lipodystrophy and they tend to have high triglycerides, a lot of times they also have the low HDL to go with it. So in terms of treatment, so we don't really treat low HDL. Because it's a little controversial. There actually have been studies trying to raise HDL levels, and so far they haven't really been effective to reduce cardiovascular risk. So it's a little bit of an area for further study and controversy right now. But to improve the number, exercise does help, and also treating high triglycerides. So kind of doing everything that you would ordinarily be doing to improve your heart health and improve your triglycerides, you're naturally going to get a better HDL out of it. And then the last lipid that I wanted to mention was lipoprotein A. You may have never heard of lipoprotein A. It's not part of the standard lipid panel, but I do want to encourage everyone to ask your doctor to get this checked at least once. So it's not part of the standard lipid panel. It needs a special order, but it is known to contribute to cardiovascular disease. It's very genetic. So a lot of times when like a family has many people in the family that have had a heart attack, when someone finally checks this level, it can be very, very high. And that was sort of the missing lipoprotein that no one was measuring, this kind of hidden ingredient that was causing their heart risk. But because it is genetic, it doesn't change that much. And so it's pretty stable for each person. And it really only needs to be checked once. If you have it and it's high, it's good to know. And if it's low, then you're sort of in the clear that you don't have a high lipoprotein A level. Right now, there's no dedicated therapy for high lipoprotein A. There are actually a lot of trials, one of which is supposed to actually result in the next year that could lead to a new medication being approved. But right now, there's no specific therapy, but it would make us intensify our treatment of LDL. So remember back to the whole, it depends if you're on a plane or in the kitchen and how, aggressive we would be with lowering our LDL. If we knew you had a high lipoprotein A, we would try harder to get your LDL to an even lower number. And so actually back to these American Heart Association guidelines, one of those risk enhancing factors is a high lipoprotein A level above 125. So if we knew that, we would try harder to lower LDL and consider you to be at higher risk of heart disease. And then just to kind of close and mention a few things, one is just that this is only lipids. So I just want to make the point that this is, one piece of a healthy lifestyle. There's sort of the Life's Essential 8, which is the American Heart Association, sort of different things to pay attention to for your overall health. Maybe some of the other lunch and learns should cover some of the other 8. I just felt like I just want to mention that lipids is only one piece of a healthy, of good health, and other things to pay attention to: blood pressure, smoking, sleep, diet, physical activity, blood sugar, and weight are all part of having a healthy heart. And so the other components are other things to think about as well. And then sort of back to this patient and the lipid panel that we got. So we had seen her high triglycerides, we had seen her LDL was pretty good, and her lipoprotein A was a little elevated. And so based on that and the fact that she had lipodystrophy and other risk factors, she had some insulin resistance, prediabetes, fatty liver. We discussed lifestyle modifications, but also did start her on a statin, atorvastatin, in order to reduce her cardiovascular risk, considering that there were some risk enhancing factors. So that's just an example. This is meant to be kind of an example of how knowing your lipid values and checking those numbers can really help to guide your treatment. So just to review some take-home messages. So a fasting lipid panel contains a lot of information. So it's helpful to know your numbers. The LDL cholesterol is the bad cholesterol. And the target depends on your overall cardiovascular risk. The higher your risk, the lower we target. Statins are the primary therapy for treating LDL cholesterol above target. And every 40 milligram reduction in LDL is associated with a cardiovascular disease reduction by 20%. But when you think about that, it really also depends on what your risk is. That's a relative reduction. So if your risk is only 2% and you reduce it by 20%, that's very small change. If your risk is 10% and you reduce it by 20%, then that's a more sizable change. For triglycerides, so the target triglycerides would be less than 150 to reduce cardiovascular risk, less than 500 to reduce pancreatitis risk. In order to improve triglycerides, it is very sensitive to lifestyle, so reducing refined carbohydrates, increasing physical activity, and also increasing consumption of the unsaturated fats like the avocado and olive oil. Statins are the primary therapy for mildly elevated triglycerides in order to reduce cardiovascular disease risk. And then fibrates would be used if your triglycerides exceed 500. For HDL, higher is better. It's a good cholesterol, but to a limit. So that's a evolving story right now, but it seems that very high is also not good. A lot of times high triglycerides go with a low HDL, and by addressing the triglycerides, you would potentially raise the HDL. But there are no therapies directly to raise HDL, and it's not really been shown that those reduce cardiovascular risk. And then lastly, lipoprotein A, the hidden lipoprotein, not part of the standard lipid panel, asked to get it checked at least once. And if it's above 125, that's considered a risk enhancer. And so that would mean there's a lower threshold to actually start a medication like a statin to reduce your overall risk. And so just to kind of close, I just wanted to show a few things about me. So one is our clinic. So I'm the Associate Director of the Lipid and Metabolism Associates Clinic at Mass General. Like I said at the beginning, we're really trying to be a home for patients with lipodystrophy and to have multidisciplinary care. We work with providers in cardiology and hepatology throughout the hospital that we work with to try to, really provide this comprehensive care to patients with lipodystrophy. So our website is there at the bottom, and happy to definitely see anyone that would like to come to Boston. I also wanted to mention the Odyssey study, which is a biorepository that we have going on that's associated with our clinic, where we are collecting specimens and data from patients with lipodystrophy in order to try to understand new mechanisms and treatments for lipodystrophy. So things that we would be doing, which actually we'll be able to provide to you for participation to be able to actually leave with some health information, are blood tests for glucose and lipid disorders, a body composition test called a DEXA, a liver ultrasound, and genetic testing. And we're also able to compensate you for your time and travel. And if you are interested, the QR code here will direct you to like a REDCap survey online where you'd be able to provide your information and we would reach out to you. Or you can email my research coordinator, Camille, and you can see at the bottom her email address. And then lastly, just to mention that we are doing a Lipodystrophy Community Day in Boston just a month from now, October 25th to 26th. And on the 25th, which is Saturday, we'll be meeting at a hotel and having lectures from expert physicians from MGH. We'll be doing some interactive games with our nutritionist, community bonding activities, and followed by a Boston Harbor cruise, which is kind of like a quintessential Boston activity in the fall. So that should be a lot of fun. If you are interested in that, you can reach out to the people at Lipodystrophy United, or you can also reach out to us as well, and we can help to connect. So again, emailing my research coordinator, Camille, at the bottom. And that's it. So happy to take questions. Hope this was helpful, and thanks everyone for joining.
Thank you so much. What an amazing talk.